Hello, everyone, and welcome to the Living Donation Week Innovation in Living Donation Care Research and Education Pitch Competition hosted by the Center for Living Organ Donation. My name is Christina Howard. I'm an investigative reporter with City News here in Toronto, and I'm very fortunate because this time last year I was recovering from a kidney transplant that actually happened right at Toronto General. Dr. Marcus Selzner, who is part of today's panel, was actually the surgeon that performed my transplant, and I'm very fortunate because my cousin Christine was a living donor, and that's why I am here today. Now, I'm going to be moderating today's discussion, but before our panelists introduce themselves, I'm just going to remind you that you can submit questions yourselves on slido.com. You can use the event code LU5. That's LU5. Now, today's session is being recorded and will be available on the Center for Living Organ Donation's YouTube channel. And without further ado, I'd like to introduce you all to our panelists. And so we have Marcus Selzner. He is the surgical director of the liver transplant program, the co-director of the abdominal organ transplant fellowship, and the Ajmera Transplant Center University Health Network. I don't know if you'd like to introduce yourself a little bit further than that.
Yeah, thank you so much, Christine. It's a great honor to be here today. Live donation is so important for our patients and for the program. And it's a great opportunity today to bring research innovation forward. And we have some of the most exciting projects we can talk about today.
And we also have the pleasure of having Anna Konvalinka, excuse me if I mispronounced your name, joining us as well. Doctor?
Thank you very much, Christina. You pronounced it perfectly. It's Dr. Anna Konvalinka, and I'm a transplant nephrologist and clinician scientist. And I'm also delighted to be part of this panel.
And also we have Melissa Sidhu, and she's actually a living liver donor. Melissa, please help us introduce yourself.
Hi, I'm Melissa. As Christina introduced me, I'm a living liver donor. I donated 65% of my liver to my younger brother on March 7, 2011, right here in Toronto at Toronto General Hospital. And I'm happy to report that my brother and I are both 9 years later in very good health, and very grateful to the transplant team. And the team has become part of our family over the years with all their support. And I'm thrilled to be part of the competition today. Thank you.
I'm really thrilled that we're able to represent both the recipient end and the donor end, and then obviously the people that make all of this possible, with Marcus and Anna being part of today's panel. So I just want to remind you all that you can submit questions through the Slido website, and that code is LU5. We have a very exciting program this afternoon. Now, there are 5 criteria that we judged certain different panelists from. We have multiple submissions that were made by several different very accomplished doctors and groups. The criteria that we did go by was the importance. So we wanted to see, was this timely, and if it addressed an unmet need or gap that had to do with the goals and mission of the Center for Living Organ Donation. We had to look at the contribution that these projects represented. So were they going to advance our knowledge and understanding, or is it going to be something that's brand new and innovative and could really change the way that transplant work is done? In terms of clarity, we wanted to make sure that it was something that was clear, something that had a very clear goal and a very good objective, and something that was actually deliverable, which comes down to the operationalization, or essentially the feasibility. We wanted to find out if we judged it based on whether the goals of the project could actually be met, and met in a timely manner. And then this was an interesting sort of criteria, is we also gauged popular support, and that was based on likes, essentially, that was on YouTube. So every team was asked to submit a short video pitch, and that was all uploaded to our YouTube page. And we really want to thank everybody for coming in and contributing to this project and submitting their very detailed research proposals when you think about it. As of last night, the 7 videos that we had received over 340 likes and many more views. So that's a pretty big accomplishment if you're trying to increase awareness of living organ donation and transplantation. And that already is a big win. So it was very difficult, I know, for a lot of us here on the panel to make decisions. None of our decisions have been finalized yet. We're waiting to see the pitches, and that is going to be available for everybody that is able to watch at home or at work, or anybody watching on their laptops or phones. Now, this pitch competition was made possible by the Toronto General and Western Hospital Foundation and its generous donors. And because of those generous donors, we were able to come up, or the center was able to come up with up to $17,500 in prize money. So up to $10,000 is going to be going to the first place winner in this competition, and it's going to cover costs associated with further research, pilot testing, or scaling the proposed project. It could also go towards mentorship and support from our distinguished faculty of educators, transplant researchers, and kidney and liver disease specialists. So this is, again, all being made in partnership with the Center for Living Organ Donation at the University of Health Network. So we did have 7 submissions that were shortlisted. They come down to Living Donation TO, a home-based dance exercise program, a scoring system for waitlisted liver patients, Transplant Talk Peer Education mobile app, the Kidney Transplant Learning Project, the Enhanced Living Donor Experience through Peer Support Program, and another study that was examining, or is aiming to examine, the disparities in liver transplant. Everybody that is making a presentation will have 2 minutes to make their pitch. We're going to have 8 minutes, which will allow panelists to ask questions and for the groups to answer and address those questions, as well as any questions that might be coming through this Slido website. Again, that's slido.com. You're going to want to use LU5 as your code. Paula Neves, the lead for the Center for Living Organ Donation, will be the timekeeper and the scorekeeper. And thank you very much to the AV team that will be coordinating. They're coordinating all of the slides right now, and they're going to be letting in each team one at a time. And first off, we're going to have Living Donation TO. I believe that they'll be joining us any minute now to talk about their project.
Hi, good morning. Can you hear me and
Yes,
see
we
me?
You are.
Wonderful, lovely to meet you all this morning. So I'll just talk to you a little bit about Living Donation TO. So with COVID-19 exposing longstanding disparities and recurring calls for sociocultural equity in healthcare, addressing living donation from a diverse cultural lens is more crucial now than ever. So, in fact, complications and barriers to living donation disproportionately affect patients and families from minority communities, largely due to communication gaps and lack of relevant resources that are easily accessible in this virtual environment, largely. This is where Living Donation TO comes in. Using valuable data and existing collaborations with various cultural organizations, we aim to build an easy-to-use web-based platform to provide accessible, tailored informational and emotional support tools for patients, potential donors, and their families. Living Donation TO aligns closely with the Center of Living Donation's mission to diversify the support we provide to patients through ethical and accessible resources for all. So we aim to achieve this through, number 1, culturally specific information resources to help navigate living donation. Number 2, stories of lived experiences and links to outreach events that users can refer to when considering their journey to living donation. And number 3, a confidential discussion forum moderated by trained volunteers to provide peer support to the cultural groups of interest. So in all of this, and in developing and consistently evaluating this user-friendly platform, we can raise awareness of benefits of living donation to more cultural communities across the GTA, strengthen the ties between center and cultural organizations while reflecting on Toronto's diversity, and finally, reducing barriers and making living donation an equitable and personable process for everyone. Yeah, that's my pitch.
Thank you very much. I do already have a question now coming to us through Slido. So excuse me as I read this off my phone, but how will you make sure the resources are diverse and representative of Toronto's populations? What specific methods will you use?
So with our research group, the Kidney Health and Education Research Group, we already have solid relationships with different communities, South Asian communities, the African and Caribbean Black communities as well, and other groups. And so we've already put out and are in the process of developing focus groups and translating a lot of informational resources surrounding the process of living donation and sort of the emotion and symptom management of the whole process. So we have translators on our team, and we have resources that are able to frame and provide the information in a culturally and in a language and in the relevant language.
It sounds like you really do have this covered, or at least you're approaching to. I have a question now coming from one of our panelists, and this is Dr. Marcus Selzner.
Yeah, thank you so much. It's a really nice and interesting project. When you create the culture-specific resources, do you have participants from these cultures to help you creating it? Do you have involvement of the groups to make sure you're addressing the key needs for each culture or group?
Thank you so much for your question, Dr. Selzner. The way we've set it up with our group and what Living Donation TO aims to leverage is that we have outreach events already happening with different cultural organizations and conversations with cultural leaders and other physicians who are representative of the diverse cultures we want to represent on the platform. And so we have conversations with them about what specific aspects of living donation that they need to know more about, or what sort of resources that they need to have available. And through focus groups and these sorts of conversations, we are using a lot of that valuable qualitative and quantitative data that our team has already in the process of analyzing, and that will largely inform the nature of the content on our website.
Okay, I have a couple of, or just quick little notes. How do you ensure that when you're dealing with individuals that may not be internet savvy? So for example, older individuals that are entering the transplant, realm and just may not have the tech savvy.
Yeah, certainly. So this was one of the major limitations that we considered, the technical literacy of our intended audience. Obviously, not everyone will be able to have access to a computer or may not be able to navigate the website as freely or as they would like compared to other users. So we have, so in developing and designing the initial drafts of our website, we really considered a lot of different aspects of disability for one thing, and also about different aspects of usability and user friendliness in terms of the small things such as the font size, button sizes, as well as larger overall layout, such that everything, all the resources, all the forums, everything, all the relevant links are within reach and within view of the screen that they may be using. And so we're following a certain consortium guidelines to make the website a lot more accessible for a wider population, for sure.
Awesome. I'm just going to reach out to the panelists and see if anybody else has any other questions. Oh, I see that, Dr. Anna, that you've got your hand up.
You're muted, Anna.
Yeah, I noticed. Sorry. I've enjoyed your presentation, and I particularly liked how you layered the background. It was very clear and very easy to follow, and also all the main points were addressed. So I thought it was very effective. My question to you is, how are you going to monitor the conversations on this website? In other words, to track and ensure that these are appropriate conversations for the intent, that if any information is exchanged, it is medically accurate and monitored, and also that there's no spamming or no uninvited users.
Yes, of course. Thank you so much, Dr. Anna. That's actually a very important issue to bring up, especially since we are planning to have a forum on the website. And we've talked at length about this, myself and my teammates that are listed on the slide. And we were thinking, this is still a work in progress, obviously, but we were thinking to have trained volunteers, students or staff who may be familiar with or have strong connections with the cultural groups that they may be moderating for the forum, and at the same time train them in resources and the latest research, and conveying that research in a way that is understandable. So that is one aspect of the moderation. In terms of the content from the users themselves, we plan on having a a set of rules, or a set of ground rules at the start, that are part of the terms of use or terms of service when people, or when users access the website. And that is one way we can help ensure that the conversations stay on topic and are not perpetrating any sort of false information, anything like that. But this is still a work in progress, and we are open to any suggestions should we be selected for further support.
Thank you so much for your presentation. I believe that your time is up. We're going to head over now to the home-based dance exercise program.
Thank you very much.
Hello, everyone. It's a pleasure for me to be here with you. I am Manuela from University of Toronto, and I am here today presenting the home-based dance exercise program, seeking your partnership in research, patients connections, and financial support of $10,000 for producing our dance exercise videos. So we will be able to make our videos for the transplant candidates, recipients, and living donors. Exercise has many benefits in both pre- and post-transplant phases. Moreover, exercise has the potential to improve living donors' recovering process after surgery. However, there is a lack of information on exercise program and physical activity in donors, and transplant recipients have been low levels of physical activity due to lack of appropriate training facilities and guidance about exercise, as well as access to fitness centers. So it is time to reduce the barriers of doing exercise for liver and kidney candidates, recipients, and living donors. Let's move by making exercise at home. We are offering you an enjoyable and motivating program set to music and different types of movements. Moreover, no dance experience is required because the goal here is not the high performance, but movement and enjoyment. With living organ donation at the UHN, we can decrease the timing in waiting list for a transplant. And also, we can help our patients to feel strong again and get their life back. We have the home-based dance exercise program and much more to offer you about exercise. Let's add a new day of birth for all the transplant recipients with much more functionality and power for better days with more quality of life. Our patients and living donors deserve our best. So let's lead the way in improving physical activity for transplant candidates, recipients, and living donors. And let's make it happen during the pandemic. Who wants to dance with me?
That was a fantastic. Thank you so much, Manuela. We already have a question coming in from Slido. So how will instructions be given to ensure all participants of varying abilities can participate, including language barriers?
So first, in the beginning of every video, we have lots of information about how they can do the exercise, what they need to perform the exercise. For example, clothes, shoes, chair and table close by them. And during the dancings, we want to have some phrases showing the patients how they need to move their bodies and what they can do and they cannot do. And to make it more feasible, we will have different levels of dance exercise programs for the patients. So we'll be able to address the right intensity for each one of our patients. That's why we need the money to make all those videos. And about the language. So for now, we have English and Portuguese speakers with us, and also we have Spanish as well. Other languages we don't have right now, but for sure will be fantastic to make partnership with our living donors and patients to be able to get their translations for other languages we don't have knowledge right now.
Thank you. We have a question now from Dr. Selzner. I see he has his hand up.
Yeah, thank you so much, Manuela. It was a very nice also video you prepared in this regard. It's very impressive, and certainly we all want to get our patients moving. So different cultural backgrounds, but have different dance preference or different dancing culture or experience. Are you planning to do something for people from different backgrounds, like North America, Europe, South America, Asia, or so, in this regard?
So yes, we do have different types of dancing. Here in this project, we are proposing a contemporary dance. So basically we can use all the rhythms, all the musics, and also we can ask the patients like what type of music you prefer, and you can dance using that music for sure. Right now, we don't think it's a good idea to be focused in a specific rhythm, because this will make the program restrict for a specific group. So we want to dance with all the songs we have or our patients want, because here the goal is the movement and how we can make our movement more functional. So we can do it using all the songs and all the rhythms.
Sounds very good. I have a question now coming to you from Anna.
Hi, Manuela. I really enjoyed your video. I thought it was really extremely effective. I don't know, but if I was to make a video, I'd go to you to figure out how to put an effective YouTube video. But I was wondering, I was surprised you didn't have a kidney on that video, a patient with a kidney transplant, but in the proposal, you proposed to do the study on the kidney and liver. So why that discrepancy?
I need to be honest with you. I am so sorry, because we were running to make the video, and in the end, in the last few minutes, we got all the images together and we saw was without kidney, but we had no time to fix it because the drawing was made in Brazil, the audio recovering here, and COVID, and the dancing in other place. So yes, unfortunately, the kidney was not in the video right now, but we are making the videos for them as well. And it happens because we were in a very rush hour and we had no time to fix it. Yes, but you're right. Sorry.
No problem. How are you going to monitor the effect of your video?
So the video with the dance video, right?
Mm-hmm.
So first, we want to assess all the patients remotely. We are going to do some surveys about physical activity, what type of the exercise the patients perform, and what type of the exercise they like to do. And we will do SPPB test, is a functional mobility test, sit to stand test, and quality of life test. Everything by video, by remote call. And then we will send them the videos, and every weekly we will make some phone calls to see how are the intensity of the exercise and what is being their perspective about the exercise. And in the end of every month, we will repeat the functional mobility assessment, this including a SPPB test and 30 seconds sit to stand, and the quality of life as SF36 questionnaire. The goal of this project is be able to have a standard exercise program for our patients, and seeing them monthly, we will be able to see the efficacy of our program.
Thank you, Manuela. We've got another question for you now coming from Slido. Is there any way to monitor participation to make sure that the people are actually engaging in the program safely? And I think that's key.
Yes. So in the beginning, before we start the videos, we will make a video call with patients and explain them the dance routine and see the space they have for dancing, and explain it's very important to have at least a table or a chair close by the patient so they can hold the chair or the table anytime they need. And it's important to wear shoes. So we will make sure they really understand it. And also they will be aware they cannot perform exercise if their clinicians do not allow it. And they need to feel good, like they cannot present any dizziness before exercise. During the dance, if they feel a little weaker or with any issue, they can sit and relax. They don't need to finish. And that's why we will call them every week to see how they perform the exercise, how easy it was, and all the barriers they figured out during the dance. And they will have our contact if they had any problem, like right after the exercise, so we'll be able to understand it. But because we will do the first assessment before the video dance start, we will be able to see the patients and make the right instructions for them, because each one has a different level of physical activity, a different level of functional mobility. So for sure, we will need to address specific feedbacks for each one of our patients. And we always invite them to dance with someone, so they can invite family to dance with them.
Oh, I really like that, Manuela. It's a chance for a whole family to engage with patients, right? And not be all by yourself. I think that's a really nice additional component to your pitch. Thank you so much for your time. This was a lovely presentation, and like you've heard all the kudos on your video, it was very, very well done. I think that's all the time that we have for you right now. We're going to have to move on to our third contestant, which is about a scoring system for waitlisted liver patients. I'm going to leave this over to Dr. I'm sorry if I'm not saying your name correctly, but Abrazar.
Good afternoon. Thank you for providing me the opportunity to present this proposal. I'm Dr. Fakhar Kazi, one of the liver transplant fellow. This pitch is about the development of a tool for referral of patients from across Canada for living donor liver transplantation. So we all know that living donation is clearly beneficial to everyone on the list, and it decreases the waitlist mortality. Currently, the data suggests high waitlist mortality of around 25 to 30%. We know that MELD scoring system has pitfalls, as I described in my video earlier. Certain subgroups may be disadvantaged, such as women, PSC, frail patients. The demand for organs has exceeds the supply these days. So most centers across the country offers only deceased liver transplant, and living donation may not be discussed by physician as an option. Hence, there is need to identify specific subgroups where it should absolutely be considered. There is also need for new scores to help patients underserved by MELD scoring system. There is currently no pathway for referral for living donation, and patients are referred ad hoc from across Canada. The idea is to develop a referral tool for patients from across the country. This would be designed for patients and physicians at other centers from across country that do not have living donation available, to help them decrease their waitlist mortality, particularly for patients who are disadvantaged by MELD sodium on the list. This will not only encourage physicians from across Canada to refer patients for living donation, but will have tangible benefits to the patients. We anticipate providing the message that living donor liver transplant is beneficial to all patients, and that patient disadvantaged by a current MELD system must be particularly referred. And this will increase the referrals to our program and help save more patients' life across the country on the waiting list.
Thank you, Dr. Kazi. Am I saying that? Thank you, Dr. Kazi. You've already got a question coming into you from Slido. How does this project, or does this project, advance equity in healthcare?
So by helping patients who are underserved by MELD scoring system, we are actually equalizing the chances for all patients to get the transplant. Also, by improving the equity and access to living donation by empowering patients to ask for referral to living donation program, particularly encouraging other centers that do not have living donation to refer patients for living donor liver transplant. That would actually increase the chances for everyone to get a transplant.
Thank you. Anna has a question for you.
So thank you. So very interesting proposal. My question is, in general, patients who get living donor organs compared to deceased donor organs tend to do better. So, although you might identify patients who are particularly likely to do better with a living donor, how is that really going to change practice? And how do you think you could impact what we do?
So what we are talking about is not the post-transplant outcomes in living versus deceased donors. right now we are talking about the waiting list outcomes, patients who are right now waiting for the transplant, and because of the MELD score, low MELD score, they are not able to get an offer for the deceased donor. So they are just waiting, and 30% of patients are dropped out of the list, either because of the medical unsuitability, or they just die because of the complications of the liver disease and are not able to make up to the transplant. So we want to actually benefit those patients and improve the waitlist outcomes.
So, but presumably if they had a living donor, you would transplant them. And if they didn't, then you're still not going to transplant them, even though that shows, even though your scoring system suggests that they would do better with a living donor transplant.
That's true, but that would actually, like we have shown in a different project that patients who are listed with a potential living donor to start with, they have a higher chances to go through the transplant. Having a potential living donor does not means that everyone would get through the living donation, because they like the donor may not be suitable while they are going through the evaluation process. However, if you compare the patients who are listed with a potential living donor versus without potential living donor, the chances of getting them through the transplant is definitely high. But what we are talking about is to identify the patients who may get extra benefit, like a subgroup of those patients. There's no doubt that living donation would definitely be beneficial for everyone.
Anna, do you feel like you've gotten a good answer there?
I guess, I'm just wondering how, unless more living donors come forward, which might be, a different way of approaching the same problem. Or, incentivizing more living donors to give to the pool.
That's true. We have to encourage them for the living donation. Like there are centers who do not offer living donation. So because they are not performing living donation, they may not necessarily discuss this with the patients when they are consulting them. So such tools can actually bring this discussion up in their consultation, and they can refer the patients to us.
Thank you. I'm going to head over to Marcus, who has his hand raised.
Yeah, thank you so much. It's such an important problem, and access to liver transplant, as you well know, is so difficult. So how are you going to validate the new score? Bringing up new scores is a major and very difficult task. How you would afterwards test that it's improved and that you are better than the current system?
Yep. So as I mentioned, we actually have designed a score. We are going to improve on it, because that score was particularly in the NASH subset, by increasing the pool to all the patients who are on the waiting list. That would be actually, we are improving on it. And then further, we actually plan to improve the pool size by including the SRDR patients, which have 150,000 transplant patients data across the US. And then we can also collaborate with Canadian Donation and Transplant Research Program and Canadian Institute of Health Research to increase the sample size, where we can actually validate our data, that particular score.
Mm-hmm. Thank you.
Thank you very much, Dr. Kazi. I'm not sure, Melissa and anybody else on the panel have any questions at all?
I just have one question, Doctor. Can you comment on the significance? How much significance did you find in the difference where you find women benefiting more from LDLT? You mentioned that earlier.
Yeah, we found that females are actually disadvantaged by the MELD scoring system. So having a potential living donor significantly improve the outcome in terms of getting a transplant.
Thank you.
I exactly cannot quote the hazard ratio exactly.
Okay. Okay. Thank you, though. Thank you.
Thank you very much, Dr. Kazi. I certainly learned a lot as a layperson about LDLT and essentially the way that whole process works. So I appreciate that. I think our time with you is wrapped right now, and we're going to move over to Dr. Hamid and Transplant Talk, which is a peer-to-peer digital navigation tool for transplant and donor education in minority communities. Dr. Hamid.
Hi, everyone. It's so nice to meet you. Let me start by painting a picture for all of you. Your spouse's kidneys are failing. Their doctor talks to you both about transplant, but the whole conversation flies over your head. You can't understand the jargon, and English isn't your first language. You don't know anyone you can reach out to for help. No one understands how conflicted you feel between supporting your partner and understanding what transplant really means. You feel stuck, hidden, and lonely. Transplant Talk changes the way marginalized people approach transplant-related conversations. It offers a novel platform for people with unique life experiences to be matched with navigators with similar backgrounds who can guide them through the transplant process. Transplant Talk aims to build a network of donors, patients, caregivers, families, and everyone in between to enable open, culturally sensitive conversations. Users will have access to tailored, culturally sensitive discussion threads and communication platforms to speak with members of the network. Now more than ever, social support for transplant recipients and caregivers is imperative. Today, Dragons, I'm asking for your financial investment and mentorship in order to develop, prototype, test, and launch the app. I will require funds to consult with user interface and user experience designers, app developers, and to effectively train the navigators before releasing the app. Through your mentorship and expertise, I will also be able to better understand the needs of transplant patients and their families. Imagine a world where language isn't a barrier to transplant. Imagine a world where race isn't a barrier to transplant. Imagine a world where income isn't a barrier to transplant. This app offers a stepping stone to that world. Join me in the climb. Let's begin the transplant conversation. Thank you for having me, but that's it for my pitch.
Thank you so much, Dr. Hamid. I really enjoyed your pitch as a recent transplant recipient. I know when I was going to my kidney clinics that language barriers were certainly a factor for many people, and I was fortunate that I didn't have to face that obstacle while dealing with all of the other difficulties. So when I read your pitch, I was very intrigued because I feel like this could help a lot of people. But my first question is actually going to come to you from Slido and the audience.
Perfect.
How can you ensure that those who join and seek a buddy aren't just joking around and aren't just trolls? And there is a second part here. And what security measures are you planning to put in place to ensure that trolls aren't infiltrating the system?
Yeah, so that's a great question. I think that would actually come in with how I'm going to be partnering with the center and coming in with like the app development portion. So the first step is to actually prototype it. And when we prototype it, we can have beta users, which means that people will be trying and testing the app and seeing how it works, and then noticing the holes and kind of filling them in. So as for security, we would definitely have all security measures such as firewalls and all these kinds of technical things to keep all the information secure and safe. And to ensure that people aren't kind of like going on the platform just to joke around, we need to make sure that there's like moderators and administrators who are always looking at the app to make sure that it's a safe space for everybody. And that also comes into play once we're prototyping and testing and realizing what issues might arise.
So I have a follow-up then. So would you have real-time moderators in place, or would these be, are you envisioning more of an AI sort of moderator?
Yeah, so I'm not envisioning real-time moderators just because of the resources. And I think that with our technological advancements available now, we would be able to create machine learning or AI interfaces to have certain like word triggers, or if they notice like certain sentence strings that they can moderate on their own. So we would just need it more from the development end than from the actual human power end.
Gotcha. And they would obviously you'd be looking at different languages.
Yes.
Marcus, I see, has a question. Let's head on.
Yeah, thank you so much. It's Toronto is such a multicultural environment that's certainly very helpful, as you're proposing. Some people are more or less likely to start conversations. Do you plan any icebreakers or prompting to facilitate conversations, get this very first exchange going? Hopefully that this will then trigger more exchanges.
Yeah, for sure. So I think the app, well, what I'm proposing is on the messaging platforms or the communication platforms, there will be some presets. So you can just look at the presets of any messages and kind of press it based on what you would like to talk about. So let's say you want to learn more about life after they donated an organ, or maybe their life right now, or anything in between. So users can go in, select a preset, send the message, and then that'll hopefully start the conversation. Where I'm kind of coming from with this idea is that a lot of prospective donors and a lot of transplant recipients already have created these networks on social media websites like Reddit and Facebook, but there isn't a good matching algorithm. So this kind of application would offer that and also offer the platform for them to talk to each other. So yeah.
Thank you. I know that Anna, has a question as well.
Great, thank you. I thought you made a fantastic pitch. I really enjoyed your pitch, and I really like how you answered questions, actually. I was wondering, why are your algorithms here going to be better at matching than other, widely used and available algorithms?
The thing is, what I'm proposing is more targeted and specific than algorithms on the wider web. Like, for example, if you're using an algorithm on a thread that you find on Quora or on Facebook, those things are not specifically made for transplant patients or transplant recipients or donors. But this kind of algorithm will take into account the nuances of donor experience. And also, the development of the app will heavily consider input from real patients and real people and what they want to see in an app manifesting like this. So that's why I think the algorithm would have an edge, just because we're getting so much input from people with actual experience and it's centered towards their life.
Great, thanks.
Yeah, I really did enjoy this pitch because I do know that a lot of times I was looking at Facebook groups and not necessarily trusting their medical advice, but at least, finding people that were going through this similar situations. And I know that I did actually develop a very good friendship with somebody who, was from Toronto, same age, same educational background, same,
exactly.
background. And we actually went through like the transplant within a month of each other. So we actually became friends through a Facebook group. So I could see the real value through this because she became one of my strongest rocks and I became one of hers. And we've just met digitally. So I think that there's a lot of value in what you're saying, and I really appreciated and enjoyed your pitch. Thank you so much, Dr. Hamid.
Thank you.
We're going to move on now to the Kidney Transplant Learning Project, and I know there were several people involved in this project, so I'm not sure who specifically is planning on presenting. But we are on the Kidney Transplant Learning Project. Jonathan Wang is part of this, as well as Emily Nyun, Lakinda Somawira. Anybody else?
I think that's me. Yeah, Kavish.
Oh, I'm sorry. Thank you.
No worries, no worries. It's a hard name.
Please, I apologize.
Kavish.
Kavish, thank you,
Yeah.
Kavish.
Hello everyone. My name is Jonathan. I'm a graduate student at Western University and represent a team of 8 research trainees that work in the UHN kidney transplant program underneath the supervision of Dr. Kim and Mr. Famori. This pandemic has forced patients to receive much of their education outside the hospital, either via the phone or through video calls. Currently, kidney pre-transplant nurse coordinators and the living kidney donor coordinators are only able to teach one patient at a time. The manuals made for patients are dense, and there's no clear way to assess their understanding and retention. This current method of patient education is time-consuming and not interactive. So the Kidney Transplant Learning Project is to develop engaging educational materials for pre-transplant kidney candidates and their donors. So how does it work? In collaboration with the pre-transplant and living donor coordinators, we will develop a series of animated videos and will supplement with summary graphics and end-of-lesson quizzes. Coordinators will be able to send patients relevant video links prior to and after the teaching sessions, and patients can review the material at their own pace and bring up any specific questions with their coordinators. Our team has experience with graphic design, storyboarding, and animation, and we are asking for a budget of $5,000 to produce the first 10 videos within the next year. There will be an immediate impact on patient education as each video is developed. We believe the Kidney Transplant Learning Project is a critical educational resource for our kidney transplant candidates and their donors, allowing them to actively participate and manage their own care. Thank you everyone for your time and attention. My teammate Kavish and I are happy to answer any questions about our project.
Thank you so much, Jonathan. We actually already got a question that just came in from Slido. Have you thought about translating these materials in any ways, beyond just providing different types of materials, but actually translating into different languages?
Yeah, that's definitely something we were thinking about. Originally, we are going to create these materials in English, and depending on how much we have left in the budget, we can definitely start translating them and then pilot them different formats of the video to see which one has the most, which one is the most effective and how many people can reach and access these materials. Jonathan, do you want to add anything onto this?
Yeah, I just want to add to Kavisha's point. I say that the strength of animated videos is that we can overlay the animation with any language that we want, and we can have subtitles in different languages as well. So in terms of accessibility for different language speakers, I think the animated video is the best route to convey information through a video format.
I do have a question. Coming from a broadcast background, and now I'm working in more longer form things, we're looking at graphics a lot in animations, and I now know how expensive quality animations cost and quality graphics.
Mhm.
Do you really think, like, is $5,000 really going to be enough in order to produce quality videos? Or do you have people within your team or within your network, your social network, that have these skills?
Right. So last year, for applying to the CST Grant of Innovation, our team was able to create an animated video within a 1-month time span. And during this time span, we didn't actually have access to the more advanced animating softwares. So part of the budget that we're asking for is to purchase these more advanced animating softwares. And we expect that a lot of the processes like storyboarding and script writing and going to our content experts, those will be very similar. And then it will be up to us students to go through the learning curve and learn the animating skills and put these into video format.
So you do have experience, and that's a huge perk and a huge benefit to this project. I'm going to head over to Dr. Selsner. Marcus?
Yeah, thank you so much. I mean, it's always impressed how patients get all this amazing information in a short time, and we expect them to understand and comprehend this. And I really feel that it's very difficult very often. Do you plan to have any feedback loop when you make an animation video? How would you know it's good? How would you get the feedback from the patient that this is now helpful and it's better what we have? How do you have a quality control?
Yeah, so I can speak to that. One portion of the video that we're hoping to achieve is an interactive component, such as a quiz or something like a summary slide. Summary slides don't really provide information, but a quiz, we can definitely monitor the results and use that to determine whether the patient understood the video from the interactive video. If there's a video that's not performing so well and the quiz results aren't doing so great, we can try to modify that video to be more similar to other videos which are performing more well. Or it may just be that the content is a little bit more difficult to grasp. Another avenue that we could look at is attending some of the education sessions that I think Heather Lannon has an education session for living liver donors, and just responding to and just monitoring the types of questions being asked, seeing how involved patients are after watching these videos compared to before watching the videos could be a great way to monitor the understanding and how effective the videos are.
Yeah, I would also just add that for creating the series of animated videos, we would have to do this quite systematically. So part of the team that we will assemble, not only would they include the content experts, but we would also want patients to review the videos to make sure that they are understandable to the layperson before we actually publish these videos in advance.
Thank you, gentlemen. Kavish and Jonathan, we've got another question to you coming from Slido. What topics do you plan to cover, and will the project still be useful after the pandemic?
Yeah, so because we only have budget for a few number of topics. We have talked to nurse coordinators about what the most challenging topics are for living donor transplant recipients and donors. A couple of the earliest topics that we'll be covering would be the overall process step by step, and how a recipient can potentially ask someone to become their donor, because that can be very challenging for some people. And obviously, without a donor, without a living donor, they will be put on the wait list for a deceased donor. And we've talked about all the negative outcomes of that compared to a living donor. So helping patients with these challenging topics can be are going to be our priority for the initial stages of this project, and we can move on to the less challenging topics as we have time. Sorry, can you repeat the other question?
The other question was, so how will you pick those topics, and will this be useful after the pandemic? But I think it seems like it will be, because nurse coordinators are very busy.
Definitely.
Yes.
Nurse coordinators only have a certain amount of time with the patients. The pandemic essentially just highlighted a problem that was pre-existing. This project and sort of digitizing these paper resources into an interactive format will always be useful. And especially as, you know, the whole of like society is moving towards a more digital platform. And of course, the paper resources will still be available. It's not trying to completely replace them, but having the option to watch a video rather than reading a book is very appealing to a lot of patients, and it will definitely continue to be useful after the pandemic. Jonathan, do you have anything to add to any of these points?
I think that's like a great answer. I would just add that part of the previous video that we created was about the different evaluation process for the kidney transplant evaluation. And that seems to be a difficult concept that we would want to make a full animated video for patients. And another topic that we would want to cover would be like the different types of waitlists. And the reason why these topics are important is sometimes these topics are specific to patients and they're not applicable to every patient. So they sometimes not in the manual, and they would require the transplant coordinators to tell patients one-on-one. And hopefully with these video links, they'll be able to send relevant video links prior to these teaching education sessions.
It sounds like a phenomenal idea, and I really do like the fact that you're not trying to completely replace those big giant binders, but adding a real value added to those binders, and perhaps alleviating a lot of the nurse coordinators' times, which will enable them to better assist other patients. So great idea. Thank you so much. I really did enjoy watching your video and reading your pitch. That's all the time we have for both of you right now. We're going to have to move on to our next submission, which is enhancing living donor experience through a peer support program. So I'm not sure if it's going to be Bronte or Stephanie or Pi that's going to be presenting.
Hi, it's me. Can everyone hear me?
I can, yes.
Yes.
Perfect. Awesome. Okay. Hello, everyone. My name is Stephanie, and my team is seeking the center's guidance and financial help in creating a novel online platform for living donor peer support. Our budget is $10,000, and our projected timeline is 1 year. Living donation is the gold standard treatment for kidney and liver failure. To become a living donor, one must undergo extensive testing, and this process is rigorous, and recovery is a critical component. Furthermore, not all candidates are cleared for donation, and sometimes suboptimal recipient outcomes can occur. We recently identified an unmet need for living donor psychosocial support, and this was echoed by patients during cursory investigations. Patients also emphasized their desire to mentor other donors. To fill this gap, we're proposing a digital platform for the exchange of donor peer support. Peer support is a way to manage uncertainty while supporting social and emotional needs related to life post-transplant. Our project objectives are to 1, offer personalized peer support to living organ donors, 2, provide a centralized platform for pre and post donation resources, and 3, uphold patient safety and accessibility standards. Prospective donors will have the option of accessing the platform at the outset of their evaluation for donor candidacy. To see our plan come to light, we'll begin by collecting staff and patient level data to evaluate the need for support and then consult with living donation and IT specialists to create the pilot platform. Next, we'll work with the staff to develop a streamlined onboarding procedure, including gaining consent and a comprehensive patient code of conduct. Finally, we'll pilot the interactive digital platform to appraise functionality and monitor quality metrics for improvements. Our aim is to enhance the living donor experience at TGH, and it will be met by launching this platform, offering resources for patient self-efficacy and the exchange of donor peer support. In collaboration with the Center for Living Organ Donation, we'll leverage local resources to create an evidence-informed platform feasible and acceptable for living organ donors near and far. Thank you.
Thank you so much, Stephanie. I really did enjoy your group's presentation or your submission. We have questions for you, several of them coming from Slido. So I'm going to go to those first. With how healthcare is moving almost completely online right now because of COVID, and it will for a long time, what will this digital platform actually look like? Can you paint us a picture?
So essentially what we have in mind is to have a very personalized system. We understand that everyone comes with their own identity and their own unique circumstances. So our aim in providing peer support is not so much on a medical sense. That's not what we want to emphasize at all. It's more about psychosocial support and emotional support through the process. So we're looking to do sort of a matching system in which, you know, you fill in qualities and to match people with similar experiences and similar situations so that we can provide as much support from someone that is relatable as possible. We've done a lot of investigation, but we want to ensure before anything's put in place that it's something that is supported by doctors, by nurses, and every member of the healthcare team in terms of them thinking that the way it is set up is most beneficial for their patients. So we're looking to get a lot of feedback from all healthcare providers before setting anything into place. That way we can have maximum efficiency and efficacy of that program.
So this is continuing from a question from Slido now. Yeah. How will you get patients of various ethnicities to participate? And what considerations have you made in order to make this equitable? And I don't even think it's just different ethnicities, but it's making sure that you reach out to a diverse group of underrepresented groups as well.
Right. So essentially the way we have it planned is within that meeting that living donors have at the onset of their candidacy, we're going to offer the program to them. And obviously it's an optional program. So if they're interested, we'll have that offered to them. And if they're not, that's okay too. Essentially, that's where the matching will come in to match people of similar ethnicities, of similar experiences. Obviously, if they speak a similar language, that would be great. And so that's kind of what we're looking into right now. However, we've heard that there's programs in which they match people simply because of ethnicities. For example, we spoke to a patient that said she was matched up with another Chinese person, but that patient was very far removed from her Chinese culture. She didn't speak the language, so she felt very out of place in that match. And kind of that she was thrown into a category. So we really would like to avoid that. And we're looking into managing all those aspects as well.
If I could also add, another thing that we're privileged to have is data collected on our cohort of all potential living kidney donor candidates. So as part of our metric for evaluation, we would be able to look at the user data from our platform and then compare that with what we know about the patient population in general to really kind of discern whether or not we're getting representation and whether or not the user levels are representative of the actual entire patient cohort of people that not necessarily just proceed to actually a nephrectomy, but people who just step forward even at the very beginning with interest in being a donor as well.
I think that's a really important addition, some additional information there, Bronte. Like it really does, it does paint a picture that you do have the data to help facilitate a lot of what you're proposing to do. Anna now has a question. Doctor?
Yeah, so Stefani and Bronte, I enjoyed particularly your video, but I enjoyed your proposal very much. I'm curious, so, you know, we have several of the groups proposing to do some peer matching. So how will the algorithm work? What will the matching be based on in your case?
That's a great question. So as I mentioned, we do have access to data from the CLICK database, which I'm sure many of you have heard of, that looks at all data from all potential living kidney donors and those who are successful as well. As we outlined in our proposal, we would still require further investigation with IT specialists to really identify what type of information we would be able to use and how we could form an algorithm. So that is something we certainly need to explore a little further, but we're feeling optimistic in the sense that we do have a really robust source of data that's reflective of our own patient population. So we can create something that is personalized to our center and specific. And then when we talk about generalizability, we could potentially emulate that method in another population, but definitely we'll need to do a little bit more investigation in that area for sure.
I'm just going to open this up to the rest of the panel. If anybody else has any other questions.
If I may ask a question, how would you read the outcome? How do you determine if your project is successful? What is your endpoint to know that was good or something has to be changed?
Thank you for your question. Essentially, we plan on not only monitoring quality metrics within the system, but also reaching out to patients and asking them directly about what's working and what's not. And we think that in terms of getting direct feedback from the patients, that's the best way to understand if the program we've created is helping them. And if it's not, then fixing the aspects that aren't working to ensure that it is then making a difference.
I think it will also be important for us to also consult with staff, because in our cursory investigations, a lot of staff members we approached mentioned that quite often patients consult them for psychosocial needs, or they consult social workers for a lot of needs that are challenging to address if it requires them to come to the hospital or if they're a little pressed for time. So hopefully we would be able to also consult with them to see if we're alleviating some of those psychosocial or emotional needs as well, and reducing their workload or burden.
Thank you so much, Stephanie and Bronte. I really did enjoy as Donna said, your video was very well done, and your pitch as well. I think that you are really targeting. It's a good target. It is an area that does need more work, and I think that you both are on board with that. We're going to head on now to our final presentation of the day. And this is by Dr. Mwadi. I hope that I'm saying your name correctly. But you're going to be looking at the disparity in access to liver transplant and post-transplant outcomes in Ontario.
Correct, yes.
Doctor, the floor is yours.
All right, so basically this work had come to me since the access and understanding disparity has been something that I've been really keen into investigating since I started medical school. As time progressed and I gained more experience, it's sort of taken the back burner in my applications and now in residency. But fortunately, I am doing a PhD in clinical epidemiology right now. So I feel like I have the tools and I have the skills that are needed to investigate this in a rigorous manner. The issue, at least like we know from other solid organ transplants, like from kidney transplant and from surgical access, we know that there are disparities in access. There are multiple ways of looking at disparity, but socioeconomic status has been one of the key factors that we've all been referring to in terms of understanding if there are any disparities or any differences in access between population with higher socioeconomic status and populations with lower socioeconomic status. So we would like to look at whether this is also the case in liver transplant and investigate whether basically whether there are disparities at the referral stage, at the transplant stage, and at the outcomes of the patient's post-transplant stage. And the goal is basically based on our findings, would be able to guide a process of a thoughtful and deliberate change of ensuring equity and equitable access throughout Ontario. I think this change will be, or the change that we can guide from this information, from this data, will be impactful throughout the province and even outside of Ontario, because once it applies here, most of the time with administrative databases, you can apply it throughout Ontario and in fact, internationally as well. And I don't know if this is me talking for too long, so please stop me if my time is up.
You still have time.
So basically, I think that it'll allow us to focus or have a focus on where we want to administer the change, whether this is in terms of raising awareness through campaigns at the primary level, where this is and at the transplant level, and whether this would be raising awareness at the patient level and ensuring that they understand what their options are, and further looking into incorporating patient preferences through eliciting their opinion and their preferences into the research in the future. But this is the future work. I think the first step for us is to look at the disparities in access for liver transplant in Ontario. And this obviously, I think in my proposal, I mentioned that this will also be split up based on, like, we're not only interested in general, like the global transplant level generally is important, but we want to stratify this as much as possible based on the type of transplant and or the type of organ donor, basically, that the patients have received.
So I have a question. Do
Yeah.
you think that, because one of the things that really popped out to me in your pitch was talking about somebody's socioeconomic status being a contributor to perhaps, I think it was implied, like a delayed referral.
Correct.
Or
Yes.
maybe potentially not even being referred.
Exactly. Yeah.
Why do you hypothesize that this is an issue?
I think it's based on what I mean, and I think a lot of this is anecdotally from what I've seen in my limited experience in clinical practice, but also based on other publications that I've seen in surgery, but mostly related to cancer. Like, we all know that lower socioeconomic status have or present to hospitals at a way later stage in their cancer, as in like stage 4, versus those with higher socioeconomic status present at an earlier stage, and hence they receive earlier care, earlier access. And it relates to the issue of access. And I think from at least what I think we could do from using ICS or using administrative databases, that we can look at who's being seen because we don't have access to referral time, but we have access to whether you are or not seen by the liver transplant. Of course, it's inferred, but it's I think the best that we can do at an Ontario level, basically.
Thank you. That is helpful. Anna has her arm raised or her hand raised. Doctor?
Yes. Thank you very much, Hala. I particularly enjoyed your background and information, and I particularly agree with you that it's really important to have a strong training behind your belt so you can ask these questions in rigorous fashion. I think it's an important question, and I wouldn't be surprised at all if there are disparities on the basis of socioeconomic status. We see it all the time now. We see it in COVID and so on. So the real question is, if you do find them, and when you do find them, and I agree this is the first step, but how do you think we might address that?
I think that it will proceed in a multi-level fashion afterwards, and we'll have to do this everybody, at least from my training, I strongly believe that some of the changes have to come at the patient level, have to come at the primary care level, but it also has to happen at the tertiary center level. So I think these are the multi-level stages that we can address, and education and information is everything. So once we have that data, once we say, here, look at the disparity in access, if somebody identifies or qualifies with a lower socioeconomic status as per your assessment, they are at a lower risk of being seen in a transplant center, they are at a lower risk of receiving a transplant or falling off the wait list, and they're at a lower or a higher risk of post-operative complications, then you can thoughtfully at least guide those interventions. So I think that it'll be first at an education stage with the primary care, the delivery of primary care, acknowledging that there is disparity, and please be cautious, or to a more thoughtful message, but please consider earlier refer for lower or patients that qualify or belong to a socioeconomic status. Same at the transplant center for our surgeons. Please be aware that there is some form of micro or a sub, I don't know what the proper terminology for it is, but some form of a not discrimination, but just these patients are somehow discriminated against, whether because of that's how their life is and their life circumstances preclude them from receiving a transplant at an earlier stage or seeing a transplant consultant at an earlier stage. And also they are at a higher risk of post-operative complications because of their how their life is structured, or if there are differences in their lifestyle based on compared, I guess, based on the socioeconomic status. And then after that, I think, sorry, if this is me talking too much, please interrupt me. But after that, I think also it's important to bring the patient's opinion into this. I think we don't do a lot of work in surgery, at least, in bringing into or eliciting and exploring patient preferences in our research. So I think the third stage, or the third and the last stage of this, would be, or maybe not really in a stage manner, but one of the things that we should do is also understand from patients, how or why do you think, or what could we be doing better? There are a lot of different methodological approaches to how we can elicit or how we can incorporate patient preferences into research. And unfortunately, I mean, surveys is one of them, and small group meetings, but there are also other more sophisticated quantitative analyses that we can do in the future that would be helpful for that as well.
Thank you. Dr. Selsner, I believe that you've got your hand raised as well.
Yep. Thank you so much, Hannah. It was a very nice project and presentation. How do you plan to deal with confounding factors, particularly rural and urban areas might coincide with socioeconomic distributions? How do you figure that out? Because for the intervention, it might be very different in the end.
So there are two different ways that we can do this, or at least three different ways that we can do this, maybe four. So the first thing is we have to identify what our confounder is. So based on my experiences in ICS, at least work, is that we do have a knowledge first of where the patients reside, which is correlated with their socioeconomic status. There's also rurality is one of the covariates actually that we have access to easily in ICS work. So we can identify whether or not patients live in a rural area. We know what the transplant centers are. We know the age, we know the gender, we know the ethnicity of the patients. So we can also, first we'll check to see if any of those are collinear, as in, do they interact in the same way, as in one of them is representative of the other? Because we don't want to adjust for too many variables that are sort of collinear or correlated in the end. The second way, to answer your second question in terms of how we address the confounders, is that we have three main methods that we use quite often, at least. Is one, we can do multivariable regression analysis. Second, we can do propensity score matching or propensity score inverse probability score weighting. I think for our purposes or for this project, we might stick to either propensity score matching or or logistic regression or Poisson regression based, depending on what our outcome is. There's also one thing that I didn't mention in the proposal, but in case anybody was wondering, I mean, every center is a little bit different, right? Like Toronto is a little bit different than Western, is a little bit different than Ottawa. Every center, there's micro differences between centers. So we can adjust for that statistically by taking into account what we call clustering. So that means that each center sort of has their own micro environment that's a little bit different than other centers. And we can actually adjust for that on a statistically. So it can either provide us per center, how are we doing, or globally in all centers, if we take into account these micro clusters or these small changes, how are we doing? Or what's the globally, how are we doing? So we can certainly adjust for that at least.
Thank you so much. I really appreciated your presentation and your pitch. It was very informative, and I think you've got a lot of good work ahead of you. The panel and I are just going to break for a couple of moments to discuss our final tallies between all of these fantastic presentations. Again, the center has up to $10,000 available to people or to groups that actually are successful in their pitches. And we're just going to break for a couple of moments and boot all of the panel or all of the pitchers out and just keep the panelists into this group. Thank you very much. Welcome back. Now all of the panelists have conferred and we've gone through all of our scores, and we didn't expect it to be this close, but it was very close. All of the presentations and pitches were phenomenal. So much so that we have a two-way tie for third place. So without further ado, I'd like to say congratulations to the Transplant Talk Peer Education mobile app and the Kidney Transplant Learning Project. Both of those teams will be receiving $3,750. They'll be splitting essentially the second and third place prize. And our final, or I guess the winner of this entire competition of Innovation in Living Donation Care, Education and Research Pitch Competition goes to Dr. Muadi from the University of Toronto and examining disparity in access to liver transplant and post-transplant outcomes in Ontario. So big congratulations. You will be receiving a $10,000 prize to go towards your research efforts and to help to develop your project. I have to give a big shout out now to the one group that did have the highest level of popular support. Her video surpassed everybody else's by quite a bit, and she had such an engaging presentation. So thank you so much to Manuela de Paulo Ferreira. Your home-based dance exercise program seems phenomenal, and it seems like something that will be of so much value to so many potential donors, to transplant recipients and people that are waiting. I really hope that your project does get lifted up and that you are able to actually pursue this, because it seems like it has just so much value. A big thank you though to all of our panelists and to those who submitted questions, and to everybody that is watching at home or at work or on your, on your phones on a bench outside at a park. Really fantastic pitches that were submitted this year, and we are just so happy with that. Just a reminder that you can check out all of the other sessions for Living Donation Week 2020 and after this, and to make sure that you stay tuned after this session for a 20-minute active dance break, and that'll be led by Manuela de Paulo Ferreira, followed by the very last session of the week, a conversation with caregivers. We are exceptionally grateful and for the generosity of our founding supporters, that's the Astellas Pharma Company and the Kearney and Cahill families. And thank you to Toronto General and Western Hospital Foundation for their continued support. Again, big applause for everybody that submitted their pitches. They were phenomenal, and it's unfortunate that not everybody could win. Thank you so much.